Thank you very much. And yeah, I had a perfect translator sitting right next to me. So actually, it was a great presentation. Now you have to send an English version to me so that I can. All right. So so first of all, again, we met last night, and I just want to say it one more time. Thank you for inviting me. It's really has been an honor, a great pleasure, and a lot of fun to come and visit you all. It's actually funny, it has happened several times in the last 24 hours. People would come up to me and speak in Spanish. And no Espanol. And they actually do not believe me. But I think after a few minutes they realize, okay, well, this person lost somewhere from some place. But it is the first impression is quite impressive and quite interesting. I will be talking to you about evidence-based medicine. Unfortunately or fortunately, things are changing a little bit in the US, but I'll get to it towards the end of it. So evidence-based medicine, the traditional method, the way we practiced, and I think most of us, the way we initially learned is from our teachers, from their experience. Relied a lot on pathophysiology. We understood the pathology, understood the physiology, and we used some of that to guide how to make decisions. And sometimes relied on our intuition. This is, I think, how this patient is behaving. This is a decision that I need to make. This is how we learn, but that is not the right way to make decisions. So evidence-based medicine, it changes the way we think about decision-making. It de-stresses or de-emphasizes or makes it less important to rely on our clinical experience, on our intuition, on even relying on just pathophysiology. What it learned, it wants us to really examine the evidence, know the evidence, and use that in a decision-making. The problem with that is that it means that we have to learn new skills. We have to learn new methods to be able to look at the evidence, be able to search for the right evidence, then be able to analyze the right evidence, and then be able to apply that in our day-to-day living. So these are all different sets of skills that some of us didn't really grow up with. We sort of have to learn it as we are practicing medicine. So that is why it's important, and that's what I would want to talk a little bit about. So as we think about evidence, this is something that I'm sure all of you know about, and I'm going to use this opportunity as a recap. Something for us to really think about together, assuming that all of you already have understanding of these study designs and study methods. In terms of thinking of medicine, there is a hierarchy. There is a way it is organized in terms of what is the highest quality evidence, what is lower, and what is lowest. So I'm showing you that right here, starting from the top to the bottom in that order. The highest level of evidence in medicine and actually in any discipline comes from a randomized controlled trial. And I will talk a little bit about that in a few minutes. Next is cohort studies. There are a few papers that have been, I think, sent out to you. We will be looking at it in the next hour or so. And some of these examples will actually come up when we look at those papers because those papers fall into these different designs. After that are case control studies. Then there are these mix of studies, cross-sectional, ecological. I'll give you some examples of that as well. Case series, we see them quite commonly in literature, but it is a lower level of evidence. And the last thing that sometimes we have to come back to and sometimes we have to rely on, but it is not really considered as a high quality evidence, which is expert opinion. When I was growing up and when I was learning, that's the main thing that we relied on. Our professors, if they said this, you do this. If the professor asks you to go sit down, you sit down. If they ask you to stand up, you stand up. But that is expert opinion and not really the true high level of evidence that we really need to seek to apply in our day-to-day living. So I'm going to use a few questions and then talk a little bit about some of these different study designs and how they might help us answer those questions. So the first question is if the new treatments, they achieve cure in patients with hepatitis C virus infection. So it's a treatment effect question. The other question could be, does sorafenib improve survival in patients with liver cancer? Again, treatment, intervention question. So that is where the randomized controlled trials are really thought to be at the highest level of evidence here, because that is the best way that one can answer an intervention-related question. And why is that the case? Why do we have to really think of randomized controlled trials when we're looking about therapy? It is because when we make decisions for treatment, they're based on so many different factors. Patients that get treatment, that got treated with interferon, they were such special patients, different types of characteristics. Patients who receive treatment versus those who do not receive treatment in our clinical practices, they're very different. And that difference is very important when you're trying to determine which treatment works or which treatment does not work. So the only way to get rid of those differences could be something that you can measure, like height, weight, alcohol, smoking, and something that you just can't measure. My commitment to medical care, my compliance to treatment that you will prescribe, unmeasurable factors. We cannot make them equal except for with randomization. So that is why it is such an important study design, because randomization is really the only way to prevent these differences that otherwise will be there between patient populations. And also there are many studies now that have looked at, and some examples, great examples, that had compared results of non-randomized studies and looked at how large the effect was for a given treatment. And then those similar questions were then answered using randomized studies, and the treatment effects were different, usually smaller in a randomized study compared to a non-randomized study. So that's why whenever it is possible, and it might not be possible in all situations, but whenever it is possible, the best study design for a treatment is a randomized control design. And there are several examples in the studies that we will be looking together that are randomized studies. So what is the way the randomized studies are done? So as you look through the studies and through the designs, there are patients that have to meet relatively strict criteria to be included in a randomized study. And that can be an issue, and I'll talk a little bit about that in a few minutes, but patients have to meet certain eligibility criteria. Then they get randomized, which the best design is blinded, which means that patients do not know where they're going to be randomized to. And the doctors and the people who are monitoring them, they do not know where patients are randomized to. And patients are then allocated to an intervention or to another intervention or placebo. And then they are followed up, and then they're analyzed in the same groups that they are in. Randomized controlled trials also could have variable qualities, though one would think that every randomized controlled trial is a great trial, but you still have to be able to look for key elements to determine if a given trial actually is a high-quality trial. So there are different criteria that have been put out by different organizations that can help you decide if it's a good study versus not a good study. I'm just going to give you brief sort of nuts and bolts of what those criteria might be. So first of all, the randomization has to be done the right way. It has to be followed as per protocol. The study groups, the purpose for randomization is to make the two groups similar. And if they're not similar despite the randomization, it means it didn't work. And that is very important to look at the table 1 in the papers where they describe the study populations in both groups to really make sure that the randomization worked and the groups are similar in all the characteristics. The groups should be treated similarly except for the intervention for what is being tested and what is being evaluated. Otherwise, all the treatments should be similar for the two groups. Follow-up It has to be complete. That's another very major area where the studies fall from the quality criteria because the patients are lost to follow-up. You have no idea what happened to the patient that you were not seeing. So that as you're reading a study, analyzing a study, it's important to look at the follow-up. Blinded assessments. As I mentioned before, doctors and the study team members, they should not know which group the patient in. The patients themselves ideally should not know which group they are themselves in. And then analyses have to be consistent with the study design. They have to be specified ahead of time. So as you're reading the papers, the statistical analysis section is important, and it should mention that some of those things were decided ahead of time and not while or after doing the study. Two things that are important as you're looking at the results. Look at how large the effect is. If this is a large study with a very 2% difference in outcomes, it might not be very meaningful. So that is what the magnitude of effect is. And the other aspect is precision. How precise is the effect? How wide or narrow the confidence interval is? And this is a little different concept, so I'm going to spend a minute talking about precision and something else which is called the accuracy or validity. Validity, the way I think about it, is the truth. How close is the study to the truth? And for us to do that, it has to be done the right way, and there has to be minimal bias. That's why the randomized control studies are good, because they minimize different types of biases. We don't have a whole lot of time to talk about biases, but one thing that I mentioned before, which was the selection, two groups are similar, that is one of the key aspects that are avoided in a randomized control trial. But the second part is the precision, which reflects the degree of measurement error. An example would be if you take my temperature with different thermometers. If they are getting the same number, the results are precise. If every time you check my temperature and it's all over the place, the results are not precise. They're very, very broad, very, very variable. And we have to look for that as well. An easy way to look for that is with the confidence interval. The broader it is, the more imprecise the results are. Here is a way that I think is the picture that I drew, and that brings this point home. So let's imagine that the center, the oval, the center part, that's the result, that's the truth. That is the truth. And here, I'm doing the same experiment or same trial 4 different times, and I'm getting different results. So if you look at A, B, C, and D, I want you to think of which one is precise, meaning all the results are similar, and which one is accurate, meaning it's actually measuring the truth. So which one, let me just say, and you can raise your hands. A,
It's precise.
but inaccurate. B, accurate but not precise, widespread. C, accurate and precise. Right there, everything is tied together, and D is all over the place. So that is an important concept to just think of as you're evaluating the studies. And I'm using this example for randomized control trials, but it could be applicable to any study design that you look at. So you're absolutely right. C is the precise and the accurate example in this scenario. So I've talked about it. Randomized control trials are really at the top of evidence pyramid, but they are not without limitations. The one major limitation that I touched briefly on was the selection criteria. When patients are included in the randomized trial, they have to meet very strict criteria. They have to be in a way you can imagine, the best patients that one can get. What it does, it limits how we apply those results to our patients. Our patients are different. They have problems with getting to the clinics. They have problems with taking the medication. They're either too sick or they're too old. So that is what is called generalizability. So randomized control trials are great. They're absolutely necessary, but they could not, actually many instances can be applied directly to our patient population. So that is an important limitation of randomized control trials. They're expensive to do. They take a lot of time. Only big pharmaceutical companies can do it. Me, you, very difficult to pull together a randomized control trial on our own resources. Looking for liver cancer, I'll talk a little bit about in the next presentation. You cannot do a randomized control trial looking for liver cancer with DAs. Just the time and the money that will go into it is just not possible. And sometimes it's just not ethical to do a randomized control trial with the knowledge that we already have. So those are the issues why we do not always do a randomized control trial, despite the fact that it is the best study design. So here's a question where you might want to do a randomized control trial, but you won't. So the question is alcohol a risk factor for liver cancer? So one can do a randomized trial where one can ask everyone on this side to drink alcohol on a very regular basis, and one can ask everyone on this side to just never drink alcohol for the next 3 years to come. So it is going to be difficult to do a randomized control trial, though you might disagree, right? You belong in this group. But for others, it would be difficult. In that scenario, there are other study designs that work best and really well for some of these questions. And again, some of the studies that we're looking at will fall into these designs. One is a cohort study. I'll talk a little bit about it, and then the case control study. So for the cohort study, it is looking at two groups that have a different exposure to a key factor that you're interested in. In this example, one group that drinks alcohol on a regular basis and one that does not drink alcohol on a regular basis. And then you follow those groups over time to determine if the outcome has happened or not. It is important to think about it because there are a few papers that we will be looking at that have used this design, and sometimes you can't figure out if it's a cohort or if it's a case series, but you're looking at people who have an exposure at the beginning, comparing with them who do not have an exposure in the beginning, and then you're following them over time to look at the outcome, if it happened or not. It is important because it can look at rare things. It can even look at multiple things. In a randomized control trial, it's impossible to randomize people to 3-4 different things. But in a cohort design, you can look at combination of alcohol and smoking and hepatitis C, for example, at the same time. It can look at temporal relationships. It can look at what happened first, and it led to the second thing. It can be done in a prospective manner, meaning you're starting really now and following patients in the future, or retrospective, where you have data that are already collected, and then you use those data, go back in time, not physically, but just in time, and starting using previously existing data and follow people over time. So we see a lot of this design, a lot of that in the literature that we have right now. Lots of studies on the liver cancer and DAs are following these designs. An example here would be effect of HIV co-infection on cirrhosis or HCC in patients with hepatitis C virus infection. And let me show you a few pictures. In this case, on your left-hand side is where the patients are starting with. So no matter where you as a researcher is in time, patients are starting at the beginning. So here some patients have hepatitis B virus infection in this example. Some patients do not have hepatitis B virus infection. They're followed over time, and in both groups, some people will get HCC and some people will not get HCC. So that's your outcome. So exposure is hepatitis B, followed people forward in time, and the outcome is liver cancer. And that's a cohort study design. Note one thing, there are two groups here. The two groups are with hepatitis B, without hepatitis B. But you will also see studies where there is just one group to start with, and that causes some confusion. There's one group to start with, but still it classifies as a cohort because then the outcomes are different. patients who get liver cancer, who do not get liver cancer. So some of the cohort design methodology can be applied to this example as well. I mentioned that before. There are some studies that are retrospective. They're using things that have happened in the past and the current, and it allows you to look at disease prevalence and incidence. Their studies, the better design studies, are those that are prospective, where exposures are measured at a time of sampling, and then patients are followed over time to see if the outcome has happened or not. Both types are very commonly used in the literature. One strength of the cohort studies is, depending on where you're sampling the patients from, they could potentially be generalizable to your patient population. So that is a strength compared to the randomized controlled trial, because there are studies, cohort studies, that are using population-based samples, in which case the generalizability is better. So in here it is showing you when we look at study sample, to sort of sit back a little bit and see where the study sample is coming from. So ideally, for any study, we want that big square that's in the background. That is the target population. That's the largest population that you want to then talk about. This is the entire population of hepatitis C virus infection in Mexico, let's just say. That's the population that you want to be able to say something about after the study. But when you are actually doing the study, or when you're reading the study, the researchers pull from a larger study population that may or may not reflect the larger population. And it is important for us as readers to make sure we understand how similar or different our study population is compared to the target population. It could be a convenience sample of all the patients coming to see in our clinic, or it could truly be a community-based sample where we're going into the communities and getting patients. So it is important to think of the study sample that came from this larger, the oval right here, to see how representative that is of the larger group that you finally want to target. Here is an example of something that we see all the time. So many studies that we see, they are of patients that are seen in our clinics. And our clinics are pretty specialized clinics. They're not general primary care or community-based clinics. And the types of patients that we see, they're different. And that's something called the referral bias. And it is important to think about that when we're looking at these studies, because that does affect the generalizability of our findings. At the same time, there are studies that are looking at more population-based samples. Ray has analyzed this database quite extensively as well. It's the NHANES database from the US that is a really truly representative sample of the US, most of the US population. And anything that you do or any paper that you read from NHANES, those results are generalizable to the larger patient population. So it is important to really know where the sample is coming from, because generalizability becomes an important issue. For looking at the quality of cohort studies, there are several things, and I want you to think about it, and we'll talk a little bit more when we look at the papers. We have to make sure that the studies are looking at the right outcomes. The endpoints have to be objective. They are not things that are difficult to measure. They should not be things that how am I feeling today sort of things, but things that are objective, measurable, and can be done consistently across everyone. For the cohort studies, the follow-up has to be long enough for the outcome to happen, and it has to be complete. Experts say that about 80% of the patients that start in the study should be followed up for it to be a good quality study. And the most important issue, because it's not a randomized study, the groups are going to be different. It is important to really know, measure, and adjust for any potential differences that would be there between the study population that can affect their outcomes. So that's what the prognostic factors are. It could be, where they're coming from, how bad their disease is, do they have any family history, smoking, alcohol? You can imagine how many differences there could be that could affect your outcome. And it is extremely important to make sure we know ahead of time, or the researchers knew about it ahead of time, and they made an effort to identify those and to measure them and to adjust for them in the analysis, because otherwise the imbalance between the two groups makes the study results invalid. So these are some of the key elements to think of as you're looking at the cohort studies and looking at their results. This design, case control design, is also something which is commonly used. The difference between cohort and case control is where you're starting from. In this example, the study starts from, in a way, the end point, the outcome. So it is comparing patients who have already met the outcome, the diseased individuals, with patients who have not met the outcome, in this case, controlled patients who haven't had that condition, and then they look backwards. So the difference between cohort studies and case control is the direction of examination. Cohort studies look forward, and case controls, they look backwards to look for exposures, look for risk factors. It's a commonly done study when we're looking for risk factors for different conditions, usually for conditions that are rare and that also have a long latency period. Things happen over a long time. For example, it could be, a good example is looking for hepatitis C virus infection as a risk factor for cholangiocarcinoma. In this case, patients who have cholangiocarcinoma, which are cases, they compared to patients who otherwise look like cases or cholangiocarcinoma patients, except they do not have cholangiocarcinoma. And the research will look backwards to see how many of those individuals had hepatitis C virus infection in the past. So here, this is showing you the example here. You're starting your time zero, or the study's time zero is at the end, when the outcome has already happened, and patients are followed backwards, looking for whether they had the risk factor or didn't, both for the cases and controls. So that's the study design. And some of the aspects that I mentioned about the cohort studies apply to this as well. I'm going to just mention ecological studies and case series briefly, and then I want to spend a little bit time about meta-analysis and systematic reviews, because I think that's where, not just that it's an important aspect of study designs and evidence, but actually something that one can create relatively quickly expertise in to start working in that area. So ecological studies are studies where we're looking at multiple groups, typically, geographically or temporally, and looking at things that are happening over time in that group. It's not individual level analysis. For example, there are studies that have looked at aflatoxin or obesity for the entire village over time and seeing if the exposure to aflatoxin is correlated with the risk of liver cancer at the population large level. But the problem with these ecological studies, it could be misleading. There is something called ecological fallacy, in which case you might think that they are correlated or not. For example, in this case, is mortality from ischemic cardiac events related to daily per capita tobacco use or smoking. One would think that the populations or the cities that have more smoking, they would die mostly of ischemic heart disease, but that's not true. Japan has a very high smoking rate, but their ischemic heart risk actually is lower. So some of these things are important to think of, and I would put ecological studies at a lower level when we're looking at rating for the evidence. Case series is also something that we commonly see. However, it is something which is considered as low quality evidence. What it is a series of patients that are seen, and usually they receive the same type of treatment, and we're looking at what's happening to that individual group without really having a comparison group. It's really not clear whether any of your treatment made a difference in what the outcomes were for patients. It's considered as a low quality evidence. However, it may be useful in some cases. It's very commonly used for reporting drug side effects. So when an FDA relies on it quite a bit, because for the drug-related side effects, you do not really, especially if it's major side effects, you actually do not want a comparison group. You want to act on it quickly. So these are important for those instances where they're time-sensitive findings, or there are such novel findings that you really want to make sure that everybody else knows about it. So we do see some case series in literature, but they're commonly considered as low-quality evidence, and actually many journals don't even want to accept case series for publication. How many in the room have been involved in doing a systematic review of literature? So quite a few people. And I'm going to spend a few minutes talking about systematic reviews, just because it is, when done the right way and using the right evidence, that is the best quality evidence that one can rely on. And the second reason is that we can, and within the group, I think, can cultivate the expertise and the competency to actually start doing systematic reviews or be engaged in systematic reviews of all sort of study designs and research that I talked about. That is, to me, the least resource intensive. It relies on a good team with a solid background and good training and a good research question. That's all that you need. But if you have the expertise and if you know the methodology and you follow the methodology rigorously, it can result in very meaningful and impactful papers, and also advanced science and research in a faster way compared to doing a randomized controlled trial or doing a large cohort study. So systematic reviews, they are attempts to identify, to then understand, and to synthesize all relevant evidence that you have on a given topic. So that is what it is. As the name implies, it's a systematic review of all available evidence. There are very specific guidelines and directions on how and what the systematic review should look like. It has to have a very clear study question. One of the examples in your handout is a systematic review. The study question has to be very, 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 very specific. And right now, what the study question is looking for is what it's called, it has to follow the PICO parameters. And does anyone know what PICO stands for? Or has anyone ever worked on a PICO question? So it is one statement, one question has to talk about the participants. It has to talk about the intervention, the comparison group, and the outcome. So study question has to have all of those elements to be a specific study question, and that is what PICO stands for. It is important to also look for, once you have a PICO question ready, it has to be pre-specified what sort of studies are you going to be looking for, or what studies the researchers looked for. They have to be selected on very specific, clear-cut criteria, and they have to be analyzed and evaluated in a very, very specific way. Meta-analysis, anyone has been engaged in a meta-analysis?
Yeah. The analysis is numeric and systematic reviews is qualitative.
Absolutely. So meta-analysis is when all the results from the systematic review can be pooled together to give one estimate, an average estimate across the different studies. What are the advantages of doing a systematic review? I'm sorry, I'm taking back meta-analysis. What are the advantages of doing a meta-analysis?
It provides a lot of information and gives us some conclusions about specific questions in a specific situation, specific population, and then we can do systematic reviews and then recommendations in guidelines.
Right. So that's the benefit of doing a systematic review. You're absolutely right. One additional benefit of doing a meta-analysis is that it gives you a precise estimate. because there could be many studies, small or large, looking at one question, and the results might not be precise enough, going back to the same diagram that we looked at. When you combine them in one system, one meta-analysis, it can give you the precision that you need from multiple different small studies. What is the risk of doing a meta-analysis? When should we not do a meta-analysis despite having done a systematic review?
There's not a lot of evidence about one.
Yep. Any other reasons? Yeah, you're not allowed to speak. Right. So I think what you mentioned, similar, that there are not enough evidence or the quality of evidence is so bad, garbage in, garbage out, that you don't want to do it. The other reason you might not want to do it if the studies, you found them, but they're too different. The term is heterogeneity. Basically, it means they're too different. They were done in very different patient populations. The outcomes are similar, but not exactly the same. There are even the concerns about the quality of the studies. So there are reasons then, even after doing a systematic review, you might not see a meta-analysis in the paper, or if you're doing it yourself, you might not want to do a meta-analysis. It could be a very active decision. I would actually recommend that because studies are too different and too heterogeneous. And in that case, just describing it qualitatively is more meaningful than artificially putting them together in a meta-analysis. And that's the reason that you do not always see it in the studies that you look at. So here, meta-analysis, these are the studies where results from individual studies are combined to provide an overall number or average effect. It is done because it's more precise compared to smaller multiple studies. And also it reduces uncertainty around that effect. Having said that, not every systematic review has to have a meta-analysis, and this is what we talked about before. It might not be appropriate if the design of the study is different, if the outcomes are different, patient populations are too different, and the quality is too bad to artificially put them together. Other things that you have to look for when you're looking at a systematic review or a meta-analysis, or if you're doing it yourself. We look at many conditions. Let's just take an example of NASH. It's a systematic review or meta-analysis on NASH. What are the questions that you will think of? Let's just say, pretend you are doing the analysis yourself. What are the different things that you have to think about before you start reviewing the papers? How is NASH diagnosed? Who made the diagnosis? Is it only liver biopsy proven NASH that you will pick up? Or is going to be any mention of NASH the way the authors decided it? Are there any patients that you will exclude? Too old, too young? All of those things have to be considered and thought of before you either do it yourself or you're even reading those studies. Interventions, looking at the effect of weight reduction. An exercise program. Any exercise program or a program that was 2 weeks long, 3 times a day, 3 times a week, 60 minutes, 20 minutes, so much variability in the same intervention that one can imagine. And those things have to be thought of ahead of time, or as you're reading it, you have to make sure that you understand how the authors of that systematic review pulled that information. And ideally, it all has to be predefined. It all has to be said ahead of time before doing the study. Was the primary outcome, or how was that different from the secondary outcome? How was that handled? And the last point, which is called heterogeneity, and it goes back to the same things that we were talking about earlier. How different are the studies, the results? Should they even be pooled together? If the results are too different from the same intervention, it means there's something going on that has to be explained. And that is important as you're thinking of systematic reviews and meta-analysis, to look at the heterogeneity of the effect. And authors have to talk about it, or you as researchers have to think about it, or us ahead of time and try to figure out how to handle those. Before I finish, I want to talk about grade. Anyone in the room has heard about grade? Yeah. All of you? Super. A grade is what you were referring to earlier, is using all the evidence, the body of the evidence, to guide recommendations. And most of the major societies have moved towards grade as they write their practice guidelines. What this is, it's another system of rating the quality of evidence. So we talked about several things, but this is trying to put it all together. And what grade does is not looking at individual studies as such, it's looking at the whole body of evidence. And the way I think about it and the way the grade thinks about it is just our confidence in that literature. How confident are we that whatever we are seeing in this body of evidence actually is the truth, is a true association. So it's just a way to put a value, a number to our confidence in the literature, and they use 4 different levels for that, but basically what that is. And they're looking at 5 different things in figuring out, in making that sort of judgment about the quality, about the confidence in the evidence. It's first the methodological quality of the study. That is what we talked about, with randomized controlled trials being the highest value, lowest risk of bias, everything else comes down. Then how direct is the evidence? It is coming from the same population that the guideline is talking about, or is it coming from slightly different patient populations? Heterogeneity, we've talked about it before as well. How different are the results? How precise, another concept we talked about, are the results? And one thing that I didn't really mention very much is the risk of publication bias. It is very common for negative studies to not get published, and there are statistical ways to even look for that. So that is also important in grades recommendation. It's widely implemented, and grade actually has training sessions for learning grade methodology. AASLD had sponsored a scholarship for somebody to go and be trained with grade working group. So there are opportunities, and this is something which is very widely accepted now. But I do not think very many people are really trained in using this methodology in a proper way. And in my opinion, that is something which is worth investing time and effort, especially if somebody has the interest, to really go get trained with the people, do it a few times, and really serve as local expert in this area, because this is not going away. So something to think about. I also provided some useful links. This is something that some of us actually taught ourselves, self-taught individuals here. Some had more formal training. Both could be done. This goes back to what Jose was saying earlier. It's a great example of reading, but really doing one yourself with a team. And once you do a few, expertise can come relatively quickly, and it's the least resource intensive in terms of publications and high impact research work. So the Cochrane Handbook, I find it very useful. It's very detailed, and if you follow it, it's designed for people to just follow it and actually make it happen. A grade working group, that also website has lots of resources, lots of training opportunities. So I would encourage you to take a look at those as well, because I think this is something worth spending time and effort. So before I end, I have to tell you that as I was preparing for this talk, I was getting a little nervous. So our president has banned the word evidence-based medicine from being used in the US in the scientific literature. And as I was thinking about this, part of me was nervous. So I do hope that I go back safe and sound. I don't get stopped at Houston airport, but I took that risk only just because I like you guys so much. But you might be seeing me coming back if I'm turned away. But thank you very much for this opportunity. I'll take any questions.
Fasiha, I have two questions. The first one is about ecological studies. I do remember that for years I was very much interested in aflatoxins, in part because we have in Mexico many silos and we accumulate corn as well. And aflatoxins are equally frequent in certain parts of the country where conditions of humidity are prevalent. When you compare with studies done in Africa. But then many more studies came with the co-carcinogen effect of hepatitis B and aflatoxins as truly one of the major factors. And I'm not sure how those studies, when they're planned to investigate aflatoxins, came to consider, for example, hepatitis B as a co-carcinogen or aflatoxins as a co-carcinogen to hepatitis B. And I'm just wondering if that could be one of those fallacies that you were talking about. And the second question is, what's your opinion of the difference between guidelines and guidance? And basically guidance without considering grades, while guidelines considering grades.
Right. So I think I would just echo what you said. For the first one, it's very possible. For the guidelines and the guidance, so guidance is a new term that we have just started to see very recently. And part of the reason that the term came to be is because the guidelines have moved towards using grade, which relies on PICO and very specific questions. So what grade, in a way, forces us to do, rightfully so, with the PICO, it makes it limit to a certain patient population. And also looking for certain types of evidence to answer that study population and the study question. The end is that we can only look at specific study populations for which there is enough good quality evidence. And the problem is that most of the patients that we see in our clinical practice actually do not have that level of evidence available in the literature. So a good example would be hepatitis B, for example. There was a guideline that ASLD worked on about a year and a half ago, 2 years ago, and all the literature that we have on hepatitis B they're on a specific patient population with specific outcomes. There wasn't enough information in it for, let's say, treating patients with cirrhosis with low DNA. A common scenario. We see those patients in our clinic. They have cirrhosis, their viral load is a little bit low, we do not really know what to do. There are no randomized controlled trials. There are no very high quality studies for that question as well. So the given grade, that question, that study population couldn't even be examined. But that is important.
Do you think that that's also a result of medicine being pushed to generate guidelines when it's very hard to establish guidelines, but we still feel more comfortable to move within certain guidance?
Right.
And perhaps we cannot fulfill all the statistical criteria for a guideline, but yes, it's probably easier, less valid if you wish, but easier to establish guidance.
I see that there is value in guidance because it provides that, it fills that gap that the guidelines are unable to do right now. It uses whatever available information is. It might not be the best, but at least it does fill the gap in our clinical needs. And also combines it with expert opinion. So though expert opinion is thought to be as a lower level evidence, it is useful when there is not much evidence or whenever the evidence is conflicting. So I think there is value in guidance. And we know the literature. That's why it's important to understand what the literature is, because you can place different recommendations in different buckets. But ASLD and other agencies, they're moving towards having both because they understand what the constraints are for guidelines.
Can I ask another question? Very quick question.
I think we're running out of time.
Okay. I'll ask you directly.
Yes, Fasiha, you mentioned evidence-based medicine from this pyramid from expert opinion up to randomized controlled clinical trials. And I would like to ask you to comment about the another source of information, which is evidence-based or real-world
Yeah.
experience, which comes sometimes after the randomized clinical trials, but opens this window to a different source of information, because trials are very specific, are very limitative. And when you open to real-world experience, you also get extra information.
Right.
And for instance, you can comment on this sorafenib experience, which is very exciting, because you have 3 months more increase in the expectation of life, but in real world experience that doesn't mean too much.
Right. Absolutely. So most of the real world studies that you will see, they will follow probably the cohort study design. So you're absolutely right, and there is a lot of value in that. We're seeing more and more of it, but in terms of the study design, that's where they will fall. But you're absolutely true, they add to the evidence.